Mm. Hey, Takashi. Takashi, can you hear me? Hello, Abby. Are you there?
Hi, John.
Hey, Abby, how you doing?
Fine. How are you?
You can't see the hordes there below
What?
the hotel.
Cannot see the what?
Hordes, the hordes of people below the window.
I can't see it.
They're behind the hotel. You can't see these. Yeah, let me get on here.
Okay.
Hi, John.
Chandra, good morning. Good day.
Hello, sir.
I wasn't sure if I could join, but my flight is delayed, so I'm good.
You're at the airport now?
No, I'm still at home.
Oh. Okay, welcome.
Hello, sir.
Hello. How are you, Abida?
Fine, sir.
Dr. Takashi, hello.
Geez, I'm trying to get him in. I can't get him in. Oh, he's coming in now.
Good evening from Tokyo, Japan.
Welcome, Takashi.
Yeah, I'm still working the year, so but I want to attend as much as possible.
Say hello to Chandra. Chandra's here and Abby's here. You met Chandra, right, Takashi?
Yeah, I know very well. Yeah.
Okay.
Hello.
Hello.
And you
good
know
evening.
Abby. You know Abby.
Maybe, yeah. I know. Yeah. The detailed anatomy. So yeah, very informative lectures.
Thank you.
Repeatedly, yeah, repeatedly study again and again.
You do a lot of anatomy, right, Abby?
Yeah, John.
You do a lot of anatomy, right?
Yeah.
She has to operate either in the lab or in the OR.
Yes, sir.
So, Abby, do you want me to, we'll introduce you, right? And do you want to?
No, I think the moderator is Dr. Yadav, right, sir?
Oh, okay. Okay, so you have the monitor? Okay, yeah, yeah, that's right. It's on the banner.
Yeah.
Paratosh Pandey.
May who I have already joined. अरे तो cavernous sinus involvement in trigeminal schwannoma इस पे जोर दे.
Mhm. I think that- See, I've has the link, right? Yeah, believe me, maybe I'll send one. Hmm. Just waiting for people to come in. See, Abby, have you got a hold of Paratosh?
I'll check. Just hang on, I'll check.
Yeah, okay.
How about I?
Yeah, I just sent a,
Okay.
what's up,
Because
Todd?
he's supposed to go first, isn't it?
Okay. There's a tool. Greetings,
Hi.
good morning, Atul.
Good evening, my dear John. How are you?
Very good, how are you?
You look fresh and fit and morning, like a morning dew.
You're staying busy, huh?
Oh, yeah. Everything okay, John?
Yeah. Yeah, well, you know, we're gonna do a lot more in Latin America broadcast with Borba.
Really?
Yeah, Borba's gonna crank it up in Latin America. Your old home. That was great. You could do a swing there across South America. That was a campaign. That was more than just a conference.
I'm going to go to Brazil and to Argentina next week, John.
Oh, you going again next week?
Yeah, after 10 days.
Oh, wow. Which one?
This is some spine meeting.
Can you share it? On
Yeah,
the
I
screen-
will.
on the screen now?
I will send it to you.
Okay.
See if you can participate, John, in that meeting.
Oh, Paratosh is here. Okay.
Dr. Paritosh is there.
Yes, he's coming in now.
Paritosh.
Sir, good evening, sir.
Good evening, Paritosh. Nice to see you.
Nice
Hello,
to see you,
good
sir.
evening.
How are you, sir?
Where are you, Paritosh? Which in Bangalore or somewhere else?
Bangalore only, sir.
Okay. Not in Maldives, huh?
No, Maldives, sir. उस समय गया था बस.
Good place, huh?
लेकिन अभी
Maldives?
कोई कोर्स
हाँ, सर.
मालदीव में कर सकते हैं परितोष.
हाँ सर,
नेक्स्ट कोर्स कैन बी इन मालदीव्स.
वैसा ही है सर. आजकल तो इंडियन फ्लाइट्स इतना महंगा हो गया है. It is
Correct.
so flights in India are so
Hardly any
expensive.
difference left.
So expensive. Almost 2 times हो गया पहले से सर. Before COVID, it almost double. prices.
Same with international travel. It is really very tough now. I think Maldives is cheap because it has become a very popular tourist destination right now.
वीजा का चक्कर नहीं है ना सर. Nothing is there in
नहीं,
visa.
वीसा का चक्कर नहीं है. श्रीलंका was the only other close by. So
And
it's
that is
either people are either going to Bangkok or Maldives. गोवा से सस्ता है.
Goa
It's,
से सर. Yeah.
गोवा से सस्ता है.
Hey, Oip is not here yet.
I is a busy man.
Okay. Chandra, what do you want to do? You want to wait a few minutes or start now with Tool?
If Atul is prepared to start, I think we can
No,
start.
Let's hear Paritosh what he has to say. Paritosh, you
आप
go
बोलिए सर
ahead.
पहले सर्जरी उसके बाद एंडोवास्कुलर वो
No,
मेरा
pehle
आप
endovascular,
बोलिए सर
endovascular. Paritosh
you
is the king.
start नहीं sir you start we are all here to see you only.
Who should I introduce? Who's gonna be hosting? Paratosh, are you gonna,
Yeah, I can host the call.
no, who's supposed to? Is you supposed to?
I is probably
I
supposed-
think Paritosh is also fine to start. No
Okay.
issues.
Okay, very good.
Because
Paratosh, where are you from? You're from India, what part?
Bangalore, Manipal Hospital,
Oh,
Bangalore.
Bangalore.
Paritosh
Okay.
is a big boss in Bangalore.
Oh no, what famous.
Okay, you ready? Ready, Paratosh?
Yeah, I'll just-
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett from Neurosurgical TV in Miami Beach. We have the pleasure of hosting another India Grand Rounds. And first, let me introduce the moderator. He was just pressed into service, Paratosh Pandey, a neurosurgeon from Bangalore, India. Welcome, Paratosh.
Thank you. Thanks, John. Great to be here. So I'll start. Yeah. All right. I'll share my screen.
Dr. Yadav hasn't joined as well.
He had some
I'll
issues.
send him a message.
Okay, Paritosh, you start.
Yes, sir.
As you can see, we're super organized.
Is it okay, sir?
Yes, not full screen yet.
Yeah. Okay. All right.
Okay, perfect.
Okay, so thank you very much, John. Thank you very much, Dr. Goel and Dr. Pujari for this opportunity. It's great to be here. I'll just discuss some interventional approaches to cavernous IC aneurysms, which is basically the standard of care. So as we all know, I didn't spend too much time on the introduction because I thought I would be last speaker and all this would be covered. But these are common intracranial aneurysms. It is very important to know that most of these are asymptomatic, and we get a lot of them either alone or with some kind of tumor. So you're seeing, you're imaging a pituitary tumor and you find a small cavernous aneurysm, or you are doing a meningioma, you see a small cavernous aneurysm. These are very, very common lesions, and the presentation is almost many times incidental. They may present with cranial nerve palsies, headaches, and very, very rarely bleed, which will not cause a subarachnoid hemorrhage, but will cause a carotid cavernous fistula. And most cavernous aneurysms really do not need to be treated or followed up, and there are very large number of overtreatments because of recent advances in endovascular treatment, which is not a healthy thing, because any treatment does have their own set of complications. So unless there is a problem, and unless there is unless these are symptomatic, these should not be treated. One word about carotid cavernous siphon or carotid siphon that we see, and it is important for interventional treatment as well, because the opening up of the devices or the stents or other things are dependent on the cavernous siphon. So if the cavernous siphon or carotid siphon is very small, which is the beta angle, which is seen on the screen here. So you draw a line which is along the petrous, you draw a line which is along the horizontal cavernous, you draw a line along with the supraarachnoid ICA. So this beta angle is the cavernous siphon, and the other angles are posterior bend angle and the posterior bend angle and the anterior bend angle. So all these angles are important, because whatever, suppose you have a device which comes from, say, here and lands up here. So it is in the bends that the problem arises. And if this bend is very acute, these create problems in putting up stents and devices. Also, to go for any, if the angle is very large, then the microcatheters and wire go up very, very easily. If they are not, then they have a difficulty in seeing. So these are important angiographic angles which should be measured along with this. So peridvessel occlusion with or without bypass has been the standard treatment of cavernous IC aneurysms even after Hunterian ligation went out of favor for more intracranial aneurysms. But cavernous IC aneurysms were classically treated with parent vessel occlusion with or without bypass. Then we started with coiling. Because these were almost always giant or large aneurysms and very wide-necked aneurysms, most of them did have to use stents. Balloons usually did not work alone. Some of them were treated with balloon-assisted coiling. The problem was that these aneurysms recurred a lot after the coiling or balloon or stent-assisted coiling. But the standard treatment for the last 10 to 10 years or something has been use of flow diverter, which we'll come to. First, we'll discuss the parent vessel occlusion. It's an excellent approach to treatment of IC cavernous aneurysms in patients who have very, very good cross flow. And the standard treatment would be to do a balloon test occlusion. There are a number of protocols for these balloon test occlusion, most of which are done most of the times it is done in the cath lab. You put a balloon very high up in the cervical carotid artery. You hypnotize the patient. You see the patient clinically for 30 to 45 minutes. Then you lower the blood pressure. There are some centers which involve SPECT or other perfusion studies as well. And if the patient does not have a clinical deficit, it is deemed to be safe to occlude that carotid. With or without bypass. There are some centers which tell that patients, especially the younger patients, should have low flow bypass regardless of the passing of balloon test occlusion or not. It is important to note that many centers do trap these aneurysms and do a craniotomy and put a clip very proximal to the ICA. Most of the times it is not required, because even if the flow is coming from the other side carotid, the pressure head of the flow is very, very low. And that is why you can just do a proximal occlusion, and a large number of time it works. These are the protocol of awake BTO. You can just do angiographic BTO as well for these patients and not do any of these large clinical things. So the thing to note is the appearance of the venous phase. So if the venous phase appears less than 2 seconds in the other hemisphere, then there is really no contraindication. 2 to 4 seconds, you should be careful and add a bypass. But greater than 4 seconds, if occlusion is really contraindicated. And if you see here in this slide where Dr. More described, there is bilateral perfusion, which is venous phase is coming at almost at the same time. And you can easily do this. Many a times there is cross flow also through the PCOM. And if there is a robust cross flow through both ACOM and PCOM, then usually these patients do pass the balloon test occlusion. But in this patient, if you see on the right side, there is venous phase is coming, while the left side almost it is gone. So these patients are contraindicated for parent vessel occlusion as well. That can be done both surgically and endovascularly. There was a paper where both common internal carotid artery could be occluded, and there was really no difference. But when you do it endovascularly, we do a bilateral puncture. To see the cross flow, we keep one in the artery which is going to be which is going to stay, and the other one which is going to be occluded. We hypertonize these patients. That is very important, because if once we occlude these carotid, the clot forms, and these clots can go antegrade, or during the occlusion, some clots can go antegrade, and it is important to hypertonize these patients. We use a large coil first just to put a basket, and then we can use which is more expensive, and then we can use very cheap fibered coil or pushable coils, which basically are used for the peripheral interventions, but in this case, we can use it for good. We can, and there is no need for trapping, as we have already seen. We do continue some low molecular weight heparin for 5 to 7 days because to prevent these thromboembolic complications for parent vessel occlusion. Now, there are different kind of stents. There are balloon expandable stents, which is used in coronary literature and intracranial vascular diseases. Most of these are not used for aneurysm treatment because they're very high radial force, and the vasculature in the carotid artery really, in the brain does not really support that. Then you have something called an open cell design. Then there is something called closed cell design. Then there are something called braided stents, which come between these open cell and closed cell flow diverter stents, and I will tell you what it is. And then there are flow diverter stents. It is important to note that open cell design or closed cell design stents like Neuroform Atlas, like Enterprise stents, all these stents have a metal of around 5%. So 5% is metal, rest of them is open. Braided stents have a slightly more metal. They are between flow diverters and open cell or the other previous stents. And these have metal anywhere between 10 to 15%. And you will hear words like Leo stents and some things like that. And then flow diverter stents, of course, have a very higher metal coverage, which is somewhere around 35 to 45%, depending on which flow diverter we are using. And hence, these have a much more metal and provide a flow diversion effect, as I will come to later. So this is what the open cell and closed cell design is there. Closed cell stents have small free cell area between the struts, and you can use it in any kind of. This is mostly was used for the carotid stents, but this design is also there in the brain stents, which are like Enterprise stent is a closed cell stent. Open cell stents have larger uncovered gaps. These are more flexible, conform to the vessel wall better, and there is less metal in smaller vessel. And so this is the Neuroform Atlas is almost an open cell design stent. See this. So as I said, open cell stents are more flexible. They conform better to tortuous anatomy. Closed cells are less flexible and difficult to open in bends and tortuosities. This flow diverter is basically a self-expanding stent. It is not a balloon expanding stent. Once the stent is a self-expanding stent, it is easier to take up across the bends and tortuosities, which the balloon expandable stents do not get it. So it is composed of 25% platinum tungsten, 75% cobalt chromium, made of 48 to 64 strands interwoven in a standard manner. So these are all flow diverter, woven with increased metal cell surface area to promote flow along the stent. But they also have enough porosity to allow for branch vessel or perforator patency. So we routinely put this across the anterocoroidal artery and posterior communicating artery, and they almost never have a stroke there. Ophthalmic artery is a different matter. I'll come to that later. There are three most important methods of action. First is that the flow remains laminar along the stent and away from the aneurysm. So it promotes the stagnation and thrombosis in the aneurysm. And later there is endothelialization of the aneurysm segments along with the stents, and then there is healing of the diseased artery. Now, there are a number of flow diverting stents now. The pipeline device was the first one, which was a self-expanding microcatheter guide wire delivered, braided mesh cylinder constructed with 48 interwoven strands of platinum tungsten and cobalt chromium nickel wire. This design resulted in 30 to 35% metal coverage area of the arterial surface wall. Then there was Surpass, which was basically cobalt chromium alloy along with radio opaque platinum tungsten wire for radio opacity. And these had 72 wires composed compared to 96 wires in this 5 mm Surpass flow diverting stents. The Fred stent is a 2-layered weave. The first is the traditional low metal coverage stent, like any of these Enterprise or Neuroform Atlas. And inside layer was with the flow diverting stent, and it's supposed to be more possible there. Then there is Silk, and there are a number of companies which all come with this thing. So coiling and stent-assisted coiling was the older method of treatment. It was basically safe, but led to very high number of recanalizations. So this is one of the examples we use. There is a cavernous carotid aneurysm. We coil this aneurysm and put a stent across it. But if you follow these things, almost all of them, or almost half of them, recanalized. This is again a pre-post picture here. Nowadays, as I said, flow diverters are the standard of care for large and giant cavernous carotid aneurysms. There are different kinds of flow diverter, silk, pipeline device, Fred, P64 surpass similar results. There is high occlusion rates, almost 90% or above. There's clinical improvement because the aneurysm thromboses and then shrinks, and the mass effect on the cranial nerve becomes less. So almost 90+% of aneurysm shrinking is there. There's loss of mass effect and clinical improvement as well. We do have to load them with dual antiplatelets. One of them has to be aspirin, and then the other one used to be clopidogrel, but there is very high incidence of resistance with clopidogrel as well. So many of us are either using prasugrel or ticagrelor. Because these are non-bled aneurysms, you can load them for 5 days with dual antiplatelets because of doing any of them. We use a triaxial system, which basically means that we use a long sheath in the common or proximal internal carotid artery. Then we take a distal access catheter, which is a 5 French or 6 French, very a supple catheter, very close to the aneurysm, or sometimes even distal to the aneurysm. And then we take a microcatheter, taken much beyond the aneurysm into the MCA. This is sometimes very difficult because there is a very large aneurysm which is present, and to maneuver the microcatheter beyond that can take a lot of time and skill. Sometimes it just goes. Sometimes what we do is we take the catheter, take a bend inside the aneurysm, then take the microcatheter out, and then take it very far beyond, and then try to straighten that microcatheter. So there are different approaches, different kind of things which is available. Flow diverter is then loaded into the microcatheter after sizing, correct sizing length and diameter. With a combination of push-pull technique, unsheathing, the flow diverter is deployed across the neck of the aneurysm. So it is important to deploy the 9 millimeter on both sides of the neck of the aneurysm if it is possible. There are many problems with this. The first problem is that the microcatheter does not go; it just stays in the aneurysm, and it can be very frustrating to take. Sometimes microcatheter goes but falls away, so we can use 2 microcatheters here, one with balloon and one with, and then straighten out the microcatheter as well. The other problem is that the proximal end does not open, or distal end does not open, or it doesn't open at bends, or there is a prolapse in the giant aneurysm itself if the aneurysm is very large. And it is important to size these flow diverters very carefully. Use a longer device in case of very large and giant aneurysm so that the aneurysm does not prolapse, and err towards a little bit of longer of device than possible. This is a patient. If you see here, there is a large cavernous aneurysm. We have taken, this is the distal access catheter. It is quite high inside the Pituitary carotid artery. We take this microcatheter here in the middle cerebral artery. Then we deploy this. We see this flow diverter here. We deploy it across this aneurysm. This is important. This is called stasis in the aneurysm. And once there is a stasis, we know that there is a good flow diverting effect at the angiographically, and these aneurysms do tend to thrombose over the next 2 to 3 months. Many a times we do add coils. So this is one of the aneurysms where we have added some coils. Whenever there is an aneurysm more than 10 to 15 mm, we sometimes add coils. There is no good way to know where the coils should be added or not added. Because there is no risk of bleeding in these aneurysms, we can just leave these aneurysms and not add coils, but adding coils promotes the thrombogenicity. So if you see this, the flow diverter is coming here and is open completely. It is important that all these flow diverters are open completely, because if they are not, then the aneurysms will there will be an endo leak, and there is thrombus formation after this. So there you have to see in various projections. We can do a vaso CT, we can do a 3D angiogram to know that all these things are very open, and then only our job is done. This is another. This is the same one where there is the stasis in the aneurysm here, and at 3 months there is really nothing here. This is another cavernous IC aneurysm. You can imagine that whatever microcatheter we'll send will first go to the aneurysm sac itself, and it can be a struggle to take it across the aneurysm. And then we go ahead and place the flow diverter here. Now, flow diverters initially were not that radio opaque, but the newer generations of the flow diverters have become much more radio opaque. This is a very sharp angle, so we know that once there is the device will come at this point, it will stop expanding. But with some kind of maneuvering, pushing, pulling, and needling that flow diverter, it does get opened. And if we see that this is where the flow diverter will come and finish it off. So this is the flow diverter. There is placement of the flow diverter. This is the stagnation of the contrast, which is there, which is a good sign here. And then at later the ICA completely remodels itself. There is new endothelialization of the vessel along the flow diverter, and you can see completely gone these things. Again, another aneurysm which was treated with flow diverters, very large, irregular shaped aneurysms. Treatment with flow diverter. Again, another aneurysm treated with flow diverter. You can see it here with this CT, vaso CT, completely expanded, aneurysm gone along in this thing. Another one, the aneurysm completely gone, these things completely, the artery completely occluded. Sometimes, as I said, we do use coils. There is no clarity on when the coils should be used, but we can use them. There is this device, we use the coils here. And this is how it looked before this thing. You see, this is the one this is the microcatheter which is present for coils. And then after placement of the flow diverter, the contrast has washed away from the circulation, but it is still there in this in the aneurysm sac, and that is a good sign. And that's what we mean by contrast stagnation. However, it doesn't mean that once there is a contrast stagnation, it will definitely thrombose, but it is a good sign. This is another large, very large cavernous aneurysm here. And if you see, we are placing a flow diverter here. This flow diverter will come till here, and then at follow-up, this whole sac is completely gone, and you don't see anything here. So flow diverter really has revolutionized the treatment of ICA cavernous as well as supraclinoid giant aneurysms. It has excellent results in these patients. Almost 90% of the times. Regarding the ophthalmic artery, whenever there is a good supply from the external carotid artery, from the internal maxillary artery to the globe, the ophthalmic artery will go ahead and thrombose gradually, but these patients almost never have any visual symptoms. So if the supply from external carotid artery is not good, then these patients will have a patent ophthalmic artery. This is what is called as a sump effect. So whenever the end organ demands the blood supply, and it's the same thing with enterocarotid artery and the posterior communicating artery, and these small vessels or perforators do remain open here, and almost 90% have more than 90% have complete resolution and minimal neck. There are definite complications which are less than 5% of patients. We can have thromboembolic complications. We can have vessel perforation. Thromboembolic complications can be lessened when by ensuring complete opening of the flow diverter and adequate heparinization and antiplatelet protocols. Vessel perforation is not a very frequent event now. Asymptomatic ICA occlusion can happen in patients who have not been antiplatelet or anticoagulated or treated with antiplatelets adequately. And then, of course, there are groin complications. A lot of patients are being treated by transradial route nowadays, but it is still not a very, very common way of treating these. CCF can be a rare complication of cavernous aneurysms, and they can rupture into the cavernous sinus. It happens, so they will have CCF, direct CCF instead of SAH. In these patients, we cannot use just flow diverter. We have to use some coils to stop the flow of the blood from the cavernous aneurysms to the vein. And in these patients, we have to use the coils. As in this patient, if you see here, there is a large cavernous aneurysm. It has ruptured into cavernous sinus. So we have gone ahead, put a flow diverter and put a stent so that there is no. So most cavernous aneurysms are asymptomatic and should be left, ideally left alone. Parent vessel occlusion was the older and standard treatment. It was good for patients with excellent cross flow. Time tested excellent results. Few late complications like formation of aneurysms after 10 years in ACOM and stuff have been noted, but really those are very rare complications. But the endovascular treatment is the treatment of choice for symptomatic IC cavernous aneurysm. And in that, flow diverter has rapidly become the treatment of choice. The alternate is bypass and occlusion. And really, I was wondering what is the role for direct surgery for these aneurysms, which I will tell us later. There are advances in flow diverters as well. So now the newer generation flow diverters come, which can be delivered through smaller microcatheters to 21 or 17 microcatheters. They are now coming loaded with some kind of blood thinners. So you can rapidly stop these blood thinners after a month's time, or in some cases use only one antiplatelet agent rather than two. This is still going on. These have become more and more radio-opaque, so we can easily see them, unlike the first generation pipeline device, which was very, very difficult to see. Many of them many of them are now very, very easy to open because of how they are made. Instead, initially all the initial complication of not opening up of the flow diverters have now rapidly gone out of window, and it has become a very easy procedure. But still, it is a stent. It is a stent with very, very high metal area, and it should be used judiciously. So with this, I thank you for your kind attention, and I thank both Dr. Goel and Dr. Pujari for this kind invitation. Thank you, sir.
Thank you, my dear Paritosh. That was indeed, you have shown some formidable and absolute dangerous and difficult cases of intracavernous aneurysm, and I am very happy to see your series now. You have collected a sizable numbers, and I'm sure you are progressing in this field like nobody else, maybe in the South. Whatever it is, I am very happy. That is one thing. Second thing is, you will be surprised. About 25 years ago, or maybe 30 years ago, doing cavernous carotid aneurysm by direct surgery was like my passion. Means I was, that was the, Vinko Dolenz was very high on card at that time. He was very famous, and he was demonstrating extradural approach, opening the cavernous sinus, going along the carotid, going inside and all. So, but we remember with quite, whether with happiness or with disgust or with unhappiness, those complications that used to happen, that kind of bleeding, even carotico-cavernous fistula, you'll be surprised that we were doing direct surgery at that time. And Parkinson had described that triangle and direct approach and putting muscle in that region and going, and all those things are completely historical. And to see how the whole gamut has changed over the years, how the things have progressed, how the interventional radiological things have progressed to a level which is quite astonishing. And I wish that you continue to do your good work and great work, and I am really happy to see what you have shown.
Thank you, sir.
Shekhar, you have to say something about Paritosh's work? Unmute.
Dr. Dipujari, you're muted. You're muted.
The question about incidental asymptomatic aneurysms, I think you have already answered that. My only question is, from your own experience, do you think that we have made progress in having better coils? Have you seen any thrombogenic complications at all? And the third question, you did say that you have not had problem with anterior choroidal and posterior communicating arteries, but have you had any delayed thromboembolism, and what is the current status of antiplatelet use?
So the antiplatelet use really varies a lot. There is really no standard protocol for these antiplatelets. A lot of people will use dual antiplatelets for 3 months and then do an angiogram. And if everything's okay, they will stop the Brilinta or clopidogrel or prasugrel and just continue the patients on aspirin for lifelong. There are newer devices which come with the antiplatelet load, the anticoagulants loaded there, so we might get rid of that as well. But it is as is there for all these stents. We do use one single antiplatelet for life for these patients, which is a very low dose aspirin and stuff. Regarding the thromboembolic complications, it definitely happens, but really it does not happen for the perforators or the anti-communicating or the posterior antichoroidal or posterior communicating. If we start deploying these stents across the bifurcations, so suppose we start from the middle cerebral artery itself, then the ACA can go away. If there is another ACA which is there from the other side, then the ipsilateral ACA will go. And the major problem of the thromboembolic complications is formation of clot inside the stent rather than closing of these vessels. The post circle of Willis is a completely different matter. So suppose you deploy the flow diverter in middle cerebral artery bifurcation. So one of the branches is at risk there. But the smaller perforators or smaller branches like ophthalmic artery, the antichoroidal artery, posterior communicating artery, they usually remain open, and really those are not a real cause for worry.
Also seen a couple of cases, of course, distal to the circle of Willis. I don't know if such a thing happens in ICA. Is that what is called the inflammatory response of the flow diverter, which can create issues of local compression and other issues?
That is, a lot of them are seen in post circle of Willis things either in the anterocommunicating or the middle cerebral artery, in those fusiform aneurysms where we do that, and we don't understand why these happen. There are incidents of distal delayed rupture as well, which happens in these aneurysms. Most of them are supracranial giant aneurysms where these delayed ruptures can happen. That happens in less than 2% of the patients, but it does happen, and nobody understands why it is happening. And once it happens, it's really bad.
But it doesn't happen in cavernous
aneurysms. And cavernous aneurysms are actually the best indications for these flow diverting devices, and it is really like magic once you see many of the very large people who have very large series. They have quiz as to where the aneurysm was, and they show the post first and then show the pre-real later. So it's really a great device, and it's only going to get better.
I'm sure Aip has some questions.
Well, Paritosh, excellent talk. I mean, of course, you talked about 3 options. One is a direct surgery, as Professor Goyal has indicated. It's historical. We have done quite a few of them. I would be happy to show some videos, although it's only of historical importance. Other, as you said, is the alternative is bypass and trapping, which I'm going to show right now. And FDs are probably now the gold standard. I mean, even though I never do it, I don't advocate it, but I guess we have to agree that it's much more less invasive. But on the other hand, I would like to make a case here for the anastomosis and what we've been following over the past years with our failures and our lessons. this is what when in my talk I would be talking about that. Primarily, I would be focusing on one case, but I can show you some other videos as well.
Why don't you, I just go ahead and show your case and discuss whatever you have to say, and then we can discuss further this issue. Okay, Aip? So I welcome my dear Aip on the show, and let us see, my dear Aip. Just go ahead.
Thank you, sir. Thank you very much. Of course, it's an honor to be talking here. I'm just sharing my screen. So I hope you can see this. Can you see this?
Yes, we can.
Yeah, so you can see that there is a right-sided giant aneurysm. This patient presented with one single episode of a stroke. And the neurologists, the medicine people had evaluated her for the stroke and found this, and then they referred to us. So it had never ruptured, it did not form a CCF, but it did not have much of a mass effect either. And she did not have any cranial nerve deficit. So we went ahead and did a DSA. And with the DSA, she showed, the MRI showed this. And with the DSA, we saw that it was pretty large aneurysm, but the contralateral flow was a bit delayed. It was there for sure. And we did the balloon occlusion test. And I don't know why is not, okay. We did the occlusion test. She passed it. So 20 minutes, she did not have any deficits. But then the chap who did the DSA, he said the flow is a bit delayed to the other side. It's very well present, but it's a bit delayed to the other side. The question was whether we should go for a high flow bypass, which is technically it's an easier bypass. Only thing is we need to harvest the radial artery. It's a much bigger bypass. But then if she did not pass, I mean, if she had not passed the 20-minute occlusion test, BTO, then we would have thought about it. So we asked around quite a lot of people. And earlier, we used to just, without any bypass, we used to occlude. And one of our cases, they developed a stroke. And this was on our minds. So BTO occlusion, BTO, passing the BTO is probably not just the criteria for, just a Hunterian ligation or trapping. So we thought we don't need a high flow bypass here. We'd rather need a low flow bypass. So we looked at the STAs and they were good STAs. So we decided that we will go for one of the main trunks and do a bypass here. This is what we did. We had opinions, all kinds of opinions, starting from high flow bypass. Some people said you should do a high flow and a low flow bypass. Some people said no bypass. Of course, some of the veterans said no bypass. If she's passed the BTO, just go ahead and trap it. FT was not an option here because this patient was poor and she wouldn't afford. We have an interventionist with us who we ask him primarily for strokes. I know that's not meant to be for anything, but we like to clip. We like to take our AVMs off, so surgically. It's because we don't know about the interventions and we believe that this surgical option is a cheaper option. I'm not saying it's a better option, but at least it's an equal at the moment. At least it's an equal plus a cheaper option. That's all I can say right now. So that's a ST graft. It's a bleeding. We bleed it and then we take the edge. This is completely done with the exoscope. So this is the AEOS exoscope. It gives me almost a total of 100 zoom here. So it's an excellent tool for bypass. You have massive magnification, and you have a 56-inch screen. So we are opening and finding a vessel, which M4 vessel, which can take the bypass. We look at the length, and then now we decide that this is the vessel. It's probably a 0.7 millimeter vessel. We find out this vessel, and then we isolate it. One of the things which is very important is all the twigs that are running from these vessels should be taken, and if you don't take them, then after you put the clips, you can see those twigs there. And these are very small twigs. They must be taken. You can see those twigs there. So these twigs must be taken. Otherwise, you put the clips on, and then they'll be back bleeding, and the field will be a bit untidy. So that's not what you want. So you raise this with a little bit of gel foam, and you put a small feeding tube suction to make sure that it is wet and dry. After that, you prepare the bypass. And once that's done, you match it. And after you match it, you do your painting job. It's very important. Your paint job. We have a set which I have designed with this ophthalmic company called Apasami. They make very fine instruments. So I would recommend these instruments for bypass. They're much better than a lot of instruments that I have seen. So we made this set with them. And then we use the Tenno 3x8, not the cutting needle, not the round needle, it's a tapered cutting. So we use that. So those are the stitches going in. We take 2 stitches on both sides. Earlier, we used to do a running suture. We now do interrupted sutures. I know there's merits and demerits for both, but if you're not really pressed for time, I generally like interrupted sutures. And then we put 4 more sutures on each side. So it's like a total of about 10 sutures. One less or one more, depends on the situation. There's nothing hard and fast here. For all the young neurosurgeons, this is a skill that you should definitely get. You should get trained for this, because there's a lot of stroke which is still being treated with just medications, recurrent TIAs, which is just treated with medications. I know I'm going on to ground which a lot of neurologists and maybe some of the neurosurgeons may argue about. The best medical treatment is the best, but no, we have seen quite a lot of TIAs which are not responding to medicine. You do a low flow bypass, it works like magic. So this is something that So you can see that's a bypass region, that's a bypass region. It's beautifully filling it. You can see all the rest of the parts filling. Now, this is after the carotid occlusion. So, and then she was discharged on the 3rd postoperative day without any deficits. So we believe, yes, probably an FD would have worked, but we believe that this is also a very good and a rather cheaper option. Now, I would probably share the screen and also show you 2 more things. One is, as Professor Goyal was talking about, the cavernous sinus dissection. Can you see this? Can you see my screen?
Yes, yes.
Yes.
Go
So
ahead.
we'll just go ahead, and so this is the beginning of the cavernous sinus dissection. So cutting the orbitomeningeal band, and then that's a clinoid, which is the beginning of your cavernous sinus dissection. So we go ahead, take sutures there, take the temporal lobe back. You can see the clinoid there. This is the temporal lobe, which is being pulled back from the cavernous sinus. Of course, you have to create space there. You expose the optic roof and the carotid, the 3rd nerve, all through the membrane of the transcavernous membrane, and then after that, so that's a cavernous sinus. That's a superior orbital fissure there. So the temporal lobe is progressively being pulled back. The cavernous sinus membrane is kept intact. So there's no injection or anything required if you're following this. Of course, if you're entering the Parkinson's, as Professor Goyal said, of course, then you need injection. But otherwise, if you are just exposing the cavernous sinus, you really don't need any injection. You just need a little bit of water and a little bit of care. That is all. So we are exposing. This is all cavernous sinus now. You can see the roof of the cavernous sinus there. And this is the cavernous sinus. This clinoid has been taken. So progressively uncovering the cavernous sinus further and further. The temporal lobe is pulled back further and further. After this, we can expose. I mean, so that is your optic now. That's your, this will be your clinoid triangle, and the exposed cavernous sinus, you can decide to go in which triangle which you want to go in. Now I'll show you, I'll show you a case where we have really gone into the cavernous sinus. So oh, I don't know why there is a music. Yeah, so you can see now, you can see, 1 second. Well, the music was from somebody else. So, so you can see here, that is V1, that is V2. And so we've opened the window between the V1 and V2, and also the Parkinson's between the 4th and V1 here. We went into the cavernous sinus because the meningohypophyseal trunk was supplying a dural AV fistula. We have packed in muscle for some of the CCFs, and it works very well. But of course, it is not a pleasant or a very elegant surgery. Once after you open the cavernous sinus, for an aneurysm, I have escaped with my dear life after I ruptured it, and I had to pack muscle into it, and I had to wait. Clipping was it was not even in the cards. So we opened the carotid. Fortunately, we had neck control, but we had not opened the head by that time, so we could not avoid the reverse flow. But once we opened, we were dissecting the sixth nerve away from the aneurysm, and it ruptured, and there was nothing we could do. We had to put in muscle into the lumen of the carotid. So, but the patient, we got away with it because although we had not done the BTO, the patient had good cross circulation. So, I mean, I wouldn't want to do any more direct surgeries, even if they are very cheap and almost free. I wouldn't really want to do them. But we have many times gone into the cavernous sinus and done. For CCFs, it's an excellent option. So we are going here. We packed it with a little bit of Surgicel, and after that, the C5 segment, the paraclaval segment of the carotid is being identified. This is the C4, C5 junction, and you can, of course, see the meningohypophyseal trunk is in this region. So you identify the meningohypophyseal trunk and put a clip on the meningohypophyseal trunk. Cannot bipolar because the sixth nerve is right here. And if you bipolar, we have done that in the past. We don't want to do that because there is almost a sure sixth nerve palsy if you bipolar. And so that is a back of the carotid. Here was the meningohypophyseal trunk. Both the branches were completely occluded, and I guess we have made the point clear. So, of course, the options would be yes, FD, which I would say right now, if you give me an option, if I'm neutral, I'm not neutral. You see, I vote for surgery. So if I was neutral, if somebody asked me, then maybe I would have chosen FD. But if not, I would definitely any day go for a high flow or a low flow bypass. Both are not technically very difficult. One can start with a high flow bypass. It is an ugly surgery. If you're using the saphenous vein, you'll make the patient ugly for life. You will have a large pulsating vein behind the ear in front of the ear, which is scary when the patient comes for follow-up. Radial artery bypass is a little bit more better. And if the patient passes the BTU and if there's delay in filling, of course, an STMC is a fantastic option. You don't have to do a high flow there. And of course, if a direct surgery, I think, I don't know, maybe for Dolench, it is an option. For Professor Goyal, it's an option. But for me, definitely not. We've gone there many times, and not for the aneurysm. The aneurysm, the only time I went there, it was a hard lesson that I would not forget, and I don't want to get into that again. So this would be my view.
Okay. See, to be neutral, to say the least, you know what? I have graduated from an era where direct surgery was the only treatment at that time. And then came in various endovascular procedures, and we have seen them develop in front of our eyes. And if I have to say, in a very neutral or whatever, there is no question in my mind that there is no role of direct opening of cavernous sinus for intracavernous aneurysms with all these devices now available. But what, the information that Paritosh said, that many of these flow diverters, Paritosh, what is the recurrence of aneurysms, and if it recurs, then what? Is there a role of surgery at that time, or bypass? Of course, is a very fantastic, but it is difficult, no question. But you think recurrence rate, what are the recurrence rates?
Sir, it doesn't recur. If it goes away, it will go away. It will not recur. The only problem is that it does not go away. So in like 5% of patients with one flow diverter or something, the aneurysm still fills. In those situations, what we do is we stop one of these antiplatelets and then wait for another 3 to 6 months. There are people who put in another flow diverter inside that flow diverter, and that can give a more flow diverting effect. But of course, the option of bypass and trapping is a very, very good option. And this is time tested. You can do either radial artery or the STMCA. And these are excellent options. And this can be utilized whenever the patient is not there. But once the aneurysm goes away, it really does not recur, because there is a sheet of endothelium which forms over the stent, and the artery completely remodels. So we haven't seen recurrence as in the terms of it has gone away and then it has come back again. So that in that sense, we haven't seen it at all.
Has there been a case where you have not been able to treat endovascular because you showed so many cases?
Yes. So I do a lot of bypasses. I have done a lot of, we have done a lot of both open. So sometimes what we do is we do BTO so there are some patients who cannot even afford anything. So in those patients, what we do is we just open up the carotid artery while they are awake in the operation theater itself and do an awake BTO. And if that is over, we just close the vessel. So it is really a very good treatment for patients who have very good cross flow combined with the STMCA bypass. But if everything considered normal, I think it is a very, very good all these are very good options. As you said, direct surgery really does not have any role. So it's either both of them are, you do a bypass or you do basically a flow diverting.
One thing I will have to say for the emerging neurosurgeons and for the young neurosurgeons and for senior neurosurgeons, that bypass techniques have to be learned. Anastomosis techniques have to be learned. They have to be used here and there. And, you just cannot say now this is a redundant procedure and all, as IPE has shown. We have to be realistic. We have to teach we have to let the younger people know that this is there and this has to be there and this has to be learned. And this has to be learned by repeated going in the laboratory, working on vessels, working on gloves, working on various tissues, learn the art of making sutures under microscope, making art of making sutures in the depth, because just making a suture in the microscope is not, simulating what goes on in the theater. Working in the depth and taking sutures is a different, and you have to do not one time practice or 2 times. You have to go hundreds of times in the lab to do one successful case. I think there is no way out that we can avoid the learning process of bypasses. This is what I have to say, because this is a fantastic neurosurgical technique and fantastic neurosurgical outcome, and it is not difficult at all for those who are in this subject for a period of time. This is difficult, all right, but not difficult to that extent that we just cannot do it or we don't want to do it. That kind of attitude has to be completely shunned and avoided. Shekhar, what do you have to say?
No, I agree with most of the things you have said. I think whenever the artery has to be sacrificed, you have to be prepared to do bypass. I think your threshold of doing a bypass, of course, depends on BTO, but you have to be very, very particular with how you conduct the test. And, many of these patients come with minimal symptoms. They are really not life-threatening disease. As you have seen, the chances of rupture are very, very low. And even if they rupture, They are not life-threatening subarachnoid hemorrhages. So I think it is extremely important how you plan, and you must learn the surgical technique of bypass if you are going to, give proper advice to these patients.
Okay, so you know what? Whilst we are on vascular things, you think, Shekhar, I talk a little bit on motor strip AVM. You think that is maybe, or you want to talk first? I follow you.
No. I am okay. I thought you were talking on trigeminal schwannomas involving cavernous sinus.
So you want me to talk on that? Because Paritosh was there, I wanted to show some,
No, sir, we
you
have
know.
seen.
Oh, we can have another session on AVM.
Review all the time.
Okay, so let me talk on trigeminal neurinomas. Wait. Sorry for that. Just a minute, my dear friend. Trigeminal neurinomas are indeed one of my favorite subjects for a very, very long time. And trigeminal neurinomas are one very straight. If you ask me what is in skull base, what is the easier or what is the best tumor to operate, is trigeminal neurinoma. And I have got a very long and very beautiful experience with these tumors. And I want to just go through this subject. Trigeminal neurinoma. This is the article I published in 2003. And at that time, my experience was 73 cases, which was the largest in the world at that time. And this article has been quite heavily cited in the literature because there are several beautiful things that were discussed in this article. One most important beautiful thing that was discussed was that after removal of trigeminal neurinomas, you can improve the facial sensations, which was as a series never discussed before. The second thing that we discussed in this beautiful article of mine was that trigeminal neurinoma arises in the region of Meckel's cave. That was for the first time discussed, that trigeminal neurinomas arise in the region where the trigeminal root enters and becomes Gasserian ganglion in this area. The third and very important thing that we discussed in the article for the first time in the literature was that this tumor in the cavernous sinus area here, this part of the tumor is between the layers of dura. Internal carotid artery is not encased by the tumor. Sixth nerve is not involved by the tumor, and you can work within the layers of the dura to remove this tumor. So this was another beautiful thing at that time in 2003. However, during that time, we had discussed that this part of the tumor in the posterior cranial fossa was like an acoustic tumor, which is subarachnoid at that time. This is what we had discussed. Subsequently, we have said in my subsequent articles that even this part of the tumor can be, in a number of times, not always, be completely intradural in location. So this anatomical information is quite relevant and quite beautiful when we are going to operate on these tumors. These facts were not discussed in the literature before. Of course, there is no question anatomy has to be learned, and anatomy has to be learned again and again. Working hard, smelling the formalin in the cadaver lab, taking instruments, taking drill, taking microscope in the cadaver lab was not easy 25, 30 years ago, 30 years or even more, 35 years ago, when we used to go, not 35, even 38, 39 years ago, we used to do with all these cavernous sinus dissection, anastomosis in the lab and all those things. I think there is no escape from this anatomical work if we have to do anything substantial in the field. So trigeminal neurinomas are relatively rare. In neurinomas, they are second only to acoustic neurinomas, and very Not very rarely, but rarely they are associated with neurofibromatosis. So these are the things with trigeminal neurinoma. So in the year, I had analyzed my series till 2017, 260 cases. So subsequently in 5 years, at least 50 or 60 or 70 more cases. So this is also the largest series in the world. There's no other publication, no other experience which is bigger than this. So trigeminal nerve is located in the lateral dural wall of the cavernous sinus. Only V1 and V2 divisions are in relationship to the cavernous sinus. V3 goes away from the cavernous sinus early here, before it actually, from the Meckel's cave, it goes outside the cavernous sinus. So V1, V2, this is third nerve, this is fourth nerve, this is sixth nerve. So these tumors, as you can imagine, located quite in the depth. And I have to also tell the young people, at least in the audience, most of you are young, that about 30 years ago, trigeminal neurinoma surgery was not very commonly done. Anatomy of trigeminal neurinomas was not really understood before the era of MRI. MRI had just come at that time. And, carotid artery relationship, cavernous sinus surgery was not real. And most of the dumbbell-shaped tumors were done in 2 stages. And this surgery was not a very popular and considered to be an absolutely horrendous or dangerous form of surgery. So the understanding of the dura has been my forte over the years. I have published at least 35 to 40 articles on dura and tumors, and how the tumors respect the dura and how the surgeon has to respect the membranes and meninges. And this was one of my articles in 1998, where I had discussed about meningeal architecture, about impact of arteries, how the arteries are displaced. As I mentioned, that trigeminal neurinoma will displace the artery, never encase the artery in the cavernous sinus. Other tumors like meningioma may encase. The most important tumor that encases the carotid artery is cavernous hemangioma of cavernous sinus. Other very, very important tumor that encases the carotid artery is pituitary tumor and other tumors. So how the arterial displacement and encasement. So these are the articles which I have talked about on several occasions in the last several years. And this, I will say, this is my personal growth in the field, and how the tumor can encase, how can encase but not squeeze and displace. So these are my historical articles, and I must tell you that some of these articles are very heavily cited in the literature. So as regard trigeminal neurinoma, they are located within the dural walls of the cavernous sinus, or interdural in location. Exactly in the same year, Vinko Dollens had talked about extradural exposure to these tumors. And I had talked within few months of each other, I had talked about interdural exposure of these tumors. So this word interdural was introduced for the first time. And there is no question in my mind that working within the confines of the dura, working within the dural membranes, can make this tumor surgery quite safe, simple, and effective. The other thing that is very important in my own career is to avoid use of coagulation and cautery within the tumor, learn the art of breaking the tumor and demolishing the tumor, and save the traversing fibers of the fifth nerve, which are usually on the dome of the tumor, not in the center of the tumor. So break the tumor. Many of these tumors are soft. Many of these tumors are necrotic. Many of them are firm and solid. So you have to have the situation, you have to handle the situation as it comes. As I mentioned, this posterior fossa component, during that time, I had said that these are subarachnoid in location. But when the tumor is multi-compartmental, when it is multi-compartment, it is always interdural. When it is not multi-compartment, only in 2 compartments, then it might just be, I will say, not more than 20% of times it is outside the dura, this component. Posterior cranial fossa, trigeminal neurinomas, only in the posterior fossa, is completely rare. they always have a tail running towards the macroscape because this is where they arise and then jump off to posterior fossa or the middle fossa or extracranial. And when there are, my strategy has been middle fossa approaches for majority of trigeminal nerinomas. But when the larger or very huge component is in the posterior fossa, even posterior fossa retrosigmoid operation is quite beautiful. And many of these cases with huge posterior fossa component, relatively small, I frequently nowadays do a retrosigmoid supracerebellar approach for these tumors. So these tumors dumble. Many of these tumors are dumble shaped. You can see there is necrotic soft areas. Learn the art of breaking the tumor. Carotid is always around in the dome of the tumor. You don't have to expose the carotid. You will not imagine, but many of these tumors, there was proximal control, distal control. I used to do it myself at that point of time, but more we learned, more we advanced. There is no need for arterial control. And many of these tumors, I must tell you that many of these tumors I removed in 35 minutes, 40 minutes by understanding, by handling the anatomy, by handling the tumor. Coagulate only when it is absolutely necessary. Many of these tumors will not need any kind of coagulation. Work within the dura, and if the posterior fossa component is in the subarachnoid space, respect and work within the subarachnoid spaces. So these tumors are one of the most beautiful dumbbells that you have seen. Apart from when you go to the gym these days, you will see Atul Goyal becoming a little strong these days because he's using dumbbells. But these are the other dumbbells which are very fascinating dumbbells to be handled. And this is a little bit pregnant dumbbell. You come, these kind of tumors with significant middle fossa component, there is no way I can go retrosigmoid. With this kind of large, you have to have middle fossa component. Earlier in my exposures were involving zygomatic osteotomies and things like that, but I will discuss as to how I change my exposure for these tumors. So small dumbbell, big dumbbell, small part, big part. So when these tumors are in the cavernous sinus posterior fossa, most important is they have very characteristic symptoms like numbness, wasting. These are very characteristic. When you see these symptoms, it is trigeminal neuronoma. No other tumor will produce such remarkable numbness, such remarkable wasting other than trigeminal neuronoma. Many of these tumors go along the cranial nerve. This is along the V1 division. And this was a rare case in a child who presented with proptosis. I had reported long time ago. This tumor along V1, along the lacrimal nerve, along the V1 division, along the V2 division. You see these are the teeth along the foramen rotundum and going like that. In the V2 division, this is going along the V3, and you see this has gone and this has come broken the teeth here and come out. This is a multi-compartmental tumor, but if you realize that all these tumors will have a middle fossa component and extracranial, and what we have recently talked about, not recently, about 10 years ago, that even the extracranial part of the tumor is within the confines of the dura. So this is along the foramen ovale. You see here a middle fossa component growth here and then goes here, and very confined tumor. Even removal of these tumors, it is very important to understand that the carotid artery is displaced, lower cranial nerves are displaced, and you have to work within the dural confines, and you can do a beautiful resection with a relatively small exposure. So this is another tumor going from posterior fossa to middle fossa to infratemporal fossa to skin. So it is multi-compartmental tumor. I had removed all the compartments in one stage, and this patient had a little bit of a aggressive postoperative course, but he's absolutely all right. All the components in one stage can be removed by understanding the dural situation. So many of my tumors are type A, means only in the cavernous, in the middle fossa, only in the posterior fossa, dumbbell-shaped extracranial. This was a slide which I had made long time ago. They can be small trigeminal nerinomas, huge trigeminal nerinomas, and very huge trigeminal nerinomas. They can be cystic and necrotic tumors, but they still are completely benign in nature. Size does not matter here, matters in the surgery, but not in the histology and not in the recurrence. I will say, I'm not sure, but size, of course, is a little bit aggressive form of tumors, necrosis within the tumor, but no matter necrosis, no matter cystic, but the dura will not be disturbed, and dural confines have to be understood. If you have to remove this tumor, attack the tumor, work aggressively within the dural. Aggression does not mean that in large tumors you damage the cranial nerve. The fifth nerve, if you damage B1, you have killed the eye. Patient will not be able to sustain corneal ulcer and all those things. So there can be huge dumbbells with necrosis. So my sizes have been quite huge and sometimes very huge, but this has been my most beautiful. So sometimes this tumor, like two types of consistency, cystic, dark cyst, white cyst. There is only one tumor which I find cysts of multiple colors, and that is craniopharyngioma. And this tumor very rarely have cysts of multiple colors. Craniopharyngiomas have cysts of multiple colors on a very frequent number. Fluid level within the cyst is a very, a big suggestion of aggressive nature of these tumors. This cyst is due to hemorrhage or due to proteinaceous content of the tumor is difficult to say, but when you open the tumor, some hemorrhagic fluid comes out. That does not mean there has been blood, but it also means a high protein content. But whenever you see a fluid level, it suggests a very aggressive form of tumor. Means these tumors are more prone for recurrences. So you see fluid with multiple fluid levels in the tumor. Can you appreciate the fluid levels within the tumor? And these multiple fluid levels, when they are there, very easy tumor, not very easy, but easier to resect, but very frequent to recur. This is a huge tumor. If you realize there are multiple fluid levels, multiple, relatively easy to remove, soft and necrotic in nature, red colored bloody fluid will come out and you decompress quickly and then break into the tumor. The dura will remain absolutely like virgin dura. Bilateral tumors are very frequent. And if you see bilateral, they are always associated with neurofibromatosis. And when they are bilateral, you have to know when to operate and when not to operate, because many of these bilateral tumors, many of these tumors with neurofibromatosis do not need to be operated, even when they have become huge size. And when to operate, when not to operate is a very big chapter in neurosurgery. And if you have to operate, you have to follow the same surgical strategy of dura, but you have to be much more conservative in your strategy in NF2 cases, as we all know. So this is one huge acoustic and one trigeminal. In a case of NF2, they are almost kissing each other. And, this one tumor on one side, one tumor on the other side, of course, you will not remove trigeminal, you will remove this huge acoustic. If it is indicated, even I will say, even this kind of huge and massive tumor, sometimes an NF2 may not produce any significant symptom. This is another case of NF2. You see there is 4th nerve tumor, there is 6th nerve tumor, there is 7th nerve tumor, there is trigeminal tumor. So there are multiple tumors possibility in NF2 cases. Another beautiful case I'm showing you is trigeminal neuronoma bilateral with ossification. So when I published my series of 73 cases, in that series there were 4 cases, but I am not sure after that how many I have seen. But calcification is a possibility because of this benign nature, long-standing nature. But so on one side cystic, one side calcification is a very unusual kind of story of these tumors. Trigeminal neurinomas are associated with retrobulbar tumor. This was hemangiopericytoma. This was trigeminal neuronoma. I have shown this picture several times in my career. Beautiful presence, and both these tumors were removed, and both this was vascular and this was removed, and then this was removed, and both these tumors, and long term this patient has been all right. So we have to know how to remove these tumors and know where these are the best tumors to be removed by those who are learning and developing into the art of skull-based surgery. So these tumors are usually in younger age, rarely in young children, and less commonly in older people. So characteristic clinical features, very important. They present with wasting, they present with sensory disturbances of the fifth nerve. I had described pathological laughter as presenting symptom in large. 4 cases I had described long time ago, and I think that this symptom is a neglected symptom, and I am not sure this I had described about 20 years ago. I must have seen at least 4 or 5 more cases of these kind of large dumbbells presenting as pathological laughter. Characteristic anatomical relationship. They are present within the dura, they displace the carotid, these kind of characteristic relationships are very important when you are going to diagnose trigeminal neurinoma. So this tumor was a tuberculoma. This was an aspergilloma. So you have to, this was a hemangiopericytoma, vascular tumor. They are never like this. So these tumors, there was something different in these tumors than trigeminal neurinoma, something different. And that, of course, that difference now we can understand on T1, T2, vascularity. It will never be so vascular, trigeminal neurinoma. So we have to know the anatomy beautifully. We have to know the anatomy completely. And we have to know neurosurgery completely. We have to do how to retract the brain, how to dissect in the tissues, how to break into the tumor. So in 1992, as I mentioned, trigeminal neurinoma surgery was quite primitive. You see, Mallis had described for the first time, I think in 1991 or 92, that these tumors should be removed in 1 stage. This was the first article Mallis had described. So in 1992, even my personal strategy was to remove these large tumors in 2 stages. So this is the tumor. I removed first the middle fossa component and then the posterior fossa component. You see, in 1992, so about 30 years ago. Then this was another case during the same time where the larger posterior fossa was removed first. And then you see this was diagnosed on CT scan. Then MRI was used. MRI was also not used so commonly at that time. So middle fossa was then, you see, complete removal in 1992 in 2 stages. Then came my understanding about the dura of middle fossa, posterior fossa, you see, dura, arachnoid. And then we started understanding and minimizing the exposures. Then we started learning how the trigeminal neurinomas will grow. And this was, of course, my several articles during those days. And we described for the first time in the literature extradural approach for tumors. You see, vascular, of course, Vinko Dollens had described, but extradural approach for intracavernous sinus tumor, this was the first article in the literature. That, of course, I use for cavernous hemangioma and of cavernous sinus. For trigeminal neurinoma, we had talked about interdural approach. And this was the book in 1996, where several of these approaches, and you see here, I just want to show you this beautiful cover page of our book, where we have done such a huge pitosectomy and displacement of carotid, this kind of work. You can imagine in 1996 on the cover page, and beauty, you see how the facial nerve has been mobilized. And this was the way we were doing all these cases. Dura, of course, was the mother of tumors, and my beloved mother, Dura, I have written several articles. Now I want to talk about my personal growth in this tumor. In 1995, you can imagine I knew exactly the interdural approach, how these tumors can be diagnosed on the presenting symptoms. So first thing, you have to diagnose that this is trigeminal neurinoma. Second thing is you have to understand that this will be within the dura. Third thing, you have to understand that the anatomy of metal scale. Fourth thing, you have to understand the infratemporal fossa. So this was my approach, infratemporal interdural approach in 1995, on the basis of so many things which I have talked about. So this tumor I removed like just opening the Meckel's cave within the dura, infratemporal interdural approach in 1995. And several tumors I removed and published at that time. Of course, I don't do much of this now. So this is the tumor in my same paper, it was published. And this was another tumor. You see, at that time, you see, Al-Mafti had written in 2001 or 2002 that these tumors which transgress the tentorial edge is the very important chapter in neurosurgery and things like that. He, of course, didn't mention my article, which I published in 1995, where we had talked about just opening the Meckel cave and removing the posterior fossa component of the tumor and middle fossa component tumor in the same stage without any basal work, pitosectomy, orbitozygomatic osteotomies, which were very commonly done at that time. So this was another tumor in the same paper, you see, removed by infratemporal interdural approach. So similar, this is of course C2 neurinoma, which also has very similar dural anatomy. This is the largest spinal ganglion. Trigeminal gasserian ganglion is the largest cranial ganglion. So same dural anatomy and same understanding of the dura, which we studied in two of my articles. One is 60 cases, which is historical, and this is current of another 50 cases. You can imagine how my understanding has grown by the experience of surgical work that we get in our country. So this is C2, this is gasserian ganglion, similar anatomy, similar surgical concepts, similar dural relationships. In my first article, we had said, like for trigeminal neurinoma, I had said that this is subarachnoid. Similarly, we had said that this is intraspinal, subdural. But then we changed our concept and we have said that even this part of the tumor is within the dura. You take an incision and you can remove this tumor in exactly 10 minutes. If you do not have the understanding, you control the vertebral artery here, control the vertebral artery here, you will take a lot of time to remove and maybe you will not able to remove. So these tumors, anatomical understanding is so important, so critical, and so beautiful to remove these tumors. These are C2 bilateral, C2 trigeminal, this is extracranial. So there is so much. Now, another thing which I had published, of course, which is also very beautiful, like the third nerve arises in the oculomotor cistern. This was the first time in the literature we discussed. And this third nerve also remains within the dura. This is a beautiful thing that we have taught for the first time in the literature, that you should not remove the dura and you should work within the confines of the dura. This we had mentioned in 2004. And this was the article. And the first time in the literature, we preserved the extraocular movement or improved the extraocular movement by doing a conservative intratumoral resection. Tumor arises in the oculomotor cistern. So that is another beautiful thing. You see, there is dura, how to preserve the dura, learn the art of breaking the tumor, preserving the fibrils of the third nerve. Sixth nerve is, of course, a different cup of tea. We are still learning and we are still trying to understand the sixth nerve schwannoma as to how. Similarly, we talked about seventh nerve neurinoma. For the first time in the literature, we discussed that these tumors arise in the region of geniculate ganglion, and both these components are within the dura. So come from here, open the dura, work within the dura, and you can attempt to save the seventh nerve. And I think this is a very beautiful thing that we discussed. Similarly, we talked of lower cranial nerve tumor. For the first time in the literature, we said that these tumors arise in the region of the jugular bulb, and then they remain within the dura. And many of these tumors, which are extracranial and intracranial, can remain within the dura. So this is also within the dura, work within the dura. And this was the first time in the literature where we mentioned as a series that consecutive patients improved in lower cranial nerve function, which has never really been discussed in the literature. So this is regarding other tumors. And this is another trigeminal. So going back to trigeminal neurinoma, this was my surgical strategy in 1996 for larger tumors, particularly dumbbell-shaped tumors. I used to remove the rim of the root of the carotid, roof of the external ear canal, roof of the mastoidectomy, subtemporal exposure. Mastoidectomy was included for the first time in the literature in this article of mine. And we then did extracranial, extradural, then work within the dura. So this was my exposure during that time. And this was my incision, beautiful incision all the time, earlier the temporalis muscle was dislocated downwards by zygomatic osteotomy. So because this tumor is at the petrous apex, we displace it anteriorly. For the first time, we describe this. And this kind of basal work that we used to do, this is 1996, which was published in my book at that time. And this was the experience, 18 cases in 1995, which I published. Then after that, I started reducing my exposure by just splitting the temporalis muscle, making a basal temporal craniotomy and working over the Meckel's cave and foramen ovale, and then working within the dura. So splitting, this technique, also a beautiful technique. So from here to here splitting, you see the splitting here and anterior displacement, splitting for a smaller craniotomy. This technique we use for larger tumors on a very regular basis. And these tumors, as I mentioned, many of these tumors can be removed in half an hour or 40 minutes. That is a very long surgical time for such necrotic tumor. Basically, what you have to do is avoid coagulation too much and also save the fibers of the fifth nerve, which is absolutely critical in these tumors. So this is another tumor come from here. Larger tumors which are going anterior, I come from front. And more larger tumor which go too much behind, I come from lateral, more lateral, not over the petrous bone here. And some of these tumors which are going more in the posterior fossa, I like to do intradural exposure, retract the temporal brain, then take an incision in the outer wall of the dura, then work within the tumor for larger tumors. So this is pre-op, this is post-op, this is pre-op. You see here, and many of the articles, if you read, they talk about petrosectomies, they talk of anterior clinoidal resection, which are absolutely not necessary for these tumors. You see, there is anterior clinoidectomy is done by the tumor. Petrosectomy and erosion of the bone is done by the tumor. You don't have to do all those things. You have to just work within the tumor and demolish it in a very beautiful manner. So as I mentioned to you, I have got more than 320 cases of these trigeminal nerinomas of all kinds, and I have been showing them on multiple occasions. Many of you in the audience have seen them on several occasions, not once, but many times, because these have, now I have stopped collecting also this material, which are, beautiful cases. And when I see trigeminal nerinomas, I get excited. Now, one thing, somebody was asking me, which tumor excites you most? What neurosurgery excites you most? I told him AVM surgery, but it excites me. It little bit titillates me. It little bit disturbs me. It gives, but trigeminal neuronoma is a happy situation, not like AVM, but that is different. This is different. And these tumors are different. You see the necrosis, open the dura, break the tumor, and you learn the art of breaking the tumor. You see, when there is a small nubbin here, like I talk about pituitary tumor, this nubbin is also dura. Don't worry about this nubbin. Work within the dura, and you will be able to remove this tumor in a very effective and a beautiful manner. So you see these large dumbbells, huge dumbbells, small dumbbells, and of various kinds of tumors that I'm showing you. And this is another tumor which I don't know. This is basal artery encased here, but I don't think this may be a trigeminal neuronoma now, but I'm sure because I have put it here, maybe a recurrent case or whatever, but it will never encase the basal artery. It has been removed in any case in a beautiful fashion. This is another tumor, and this has been removed, these dumbbells. You see, these are very, this kind of multicystic with fluid levels are bound to recur if you don't remove them completely. And these are the tumors. Cystic necrotic tumors are also prone for recurrence on a more frequent basis. So you see these tumors and you enjoy these tumors. And this is a large cystic tumor where this is recurrence after removal of that tumor. And then, of course, now I have talked about recurrence of tumor, and I have talked that recurrence also is within the dural confines. This is another beautiful thing about trigeminal neuronoma. So you see, now I've talked about extracranial extension. As I showed you, V1, V2, V3, this is also within the dura. And I have talked about transcranial route for extracranial tumor. You have heard for extracranial route for cranial tumors in skull-based tumors. So this is a reverse skull-base approach. I use transcranial route for extracranial tumor, which is extracranial extension, dura is present, cranial route. So I call it reverse skull-base approach for these tumors. So you see this tumor along the V1, and you have to remove within the dura. And this tumor, you see this NF2 patient with coming out, and then you have to remove it beautifully, multiple compartment. I removed it beautifully, and there was a huge recurrence in this tumor. And this is extracranial, and this is another patient, of course. And this is a tumor where you work within the dura and remove. So when the tumor recurs, there is an apoplectic recurrence. And this was published in World Neurosurgery recently, where I talked about 7 cases. And the tumor, majority of them, if you read this article here, it is mentioned cyst at the recurrence shows well-defined fluid level. So fluid level recurrence is much more. And when they recur, they are within the dural confines. That is also beautiful. So when they recur, they are still within the dural confines, and you can do a very rapid and quick job of resection of these tumors. You see, this is postoperative. This is another massive tumor with recurrence in an apoplectic fashion. These are all mentioned and discussed in my article on that subject. Chordomas will displace the carotid artery anteriorly. Trigeminal will displace. This is chordoma, beautiful article I had written, displace the artery anteriorly. Trigeminal will displace the artery medially, and so chordomas are different, trigeminal nerinomas are different. This is one small video which I wanted to show you, but I know I have taken a little bit too much time off from this presentation. Just by the time Shaker is getting ready, I want to show you few. You see how chordomas can be removed, how beautiful exposure. It is not always nose that you have to do from the nose and all those things. It is not only endoscopic chordomas. Transcranial route is still there to be beautifully exploited. And you see how the carotid is under control, how the cavernous nerves are under control, how the 6th nerve is under control, and how you can do this operation under absolute control. So thank you very much, my dear friends, and I hope you enjoyed this rather big presentation. Thank you very much. And if you have any questions for me, I will be happy to answer. John?
Yes, any questions or comments from the residents at all? I think we have a good number of them watching. Now's your chance.
Dr. Yadav joined us at all?
No, he's stuck in, he's traveling.
Oh,
So what we can
I
do,
may
John,
have
is,
some comments or questions.
Ip, you have any questions?
I would talk about chordoma a little bit, Atul.
Yeah.
I think we are talking of complementary status of various treatments.
Yeah.
Shall we?
Let us see if there is any question. Yeah, Ip, you have any question?
Now the chordomas, there was a time when I used to do it cranially, but then these days we do everything through the endoscopic approach, and it is proven to be quite easier, much more easier. Although I have started endoscopic approaches only for the last 4 years or so, it's still proving to be a pretty easy route for us. Recently, we did a lesion where I think I showed it last time. It was we did a brainstem lesion which came out as chordoma. It's crazy because the dura was completely normal. We went in through the endoscope. There was no other route actually because the pons was like a cup and the lesion was inside it. So we went ahead and we took out the lesion. I hope I had shown it last time, probably.
Yeah, I'm not
so
saying, you know what, I'm not saying that endoscope is not a useful tool for chordomas. Chordomas are extradural tumors. Chordomas arise from the, from the clivus, they extend extracranial. But there is still a scope, and quite a significant scope, for transcranial route, where
Absolutely.
the approach is possible and better. You see, particularly when the tumor extends too much in the posterior cranial fossa. I will talk on chordomas maybe in the next lecture. I have not talked much on chordomas in
I
this
think
lecture.
you can probably show that case next time, and we can probably talk about clavicle and mainly
So
concentrating on
Shekhar, you
chordoma.
want to start your presentation? We can have
Yeah.
discussion at the end. Okay. So
Can I share my screen, John?
Yes.
Sure.
So I hope I don't take too much time, but I need at least 20 minutes. Do we have that much time?
Yes, we do.
Okay. So basically, my talk for the day is the cavernous sinus to be approached by endoscopic endonasal approach. And I have never used it for vascular lesions. So it would be predominantly exclusively about tumors. I think you have already heard about surgery of cavernous sinus and the pros and cons and the difficulties, etc. And Atul has made it look very easy. I must tell you that Giorgio Frank from Bologna, Italy, was the first person who actually advocated endonasal surgery for cavernous sinus lesions and wrote the first paper on this. Though there has been cadaveric dissection, etc., described earlier, and he was instrumental in us getting into the cavernous sinus when he actually came to our place to conduct a workshop. And I'll just take you through some of the cases which we have done so far. So basically, I think everywhere, like Atul always says, I think dura is important, and you must understand that though it is a completely structure which is encompassed within dural boundaries, there are compartments, and these compartments are basically, we talk about them with the relation of ICA. So the medial, superior, lateral, and inferior, he very nicely told us about the trigeminal being lateral and most of the displacement being superior, and the only encasing tumor is the pituitary. So the general consensus is whatever is medial to the ICA, you can do it endoscopically. Whatever is lateral to the ICA, you must do transcranially. And there are, of course, the inferior and superior compartments remain a little bit of a issue as to where it belongs. And you can see very nicely that the most important tumor and the most common tumor which invades the cavernous sinus is the pituitary tumor, and about this a lot has been written about this by several people, notably NOSP, and Atul has also written something about it, and we'll come to that in a moment. I think what I would say is that, like the Parkinson's triangle and various other approaches we have talked about transcranially, you must understand that the endoscopic endonasal approach, the number 10 and 11 have been put in this complex picture, are the areas which can be very, very safely treated by the endoscopic approach. And even in endonasal endoscopic approaches, there are three kinds of approaches. The most common approach which most of us have done, and I will predominantly talk about, is the midline transphenol endoscopic approach, where a salar lesion actually goes into the medial wall of the cavernous sinus, which is probably the weakest. And that is probably, you have to decide when you can take it. And from examples, you will understand that it is the mode of invasion of the cavernous sinus, the degree of involvement of the or the encasement of ICA, and the texture of the tumor or the morphology of the tumor, which matters there. When you have a lesion going either inferiorly or laterally, then the other two components come into picture, which are the ethmoid pterygoid sphenoidal approach. And there is a one approach where you don't actually go into the sphenoidal sinus. It is the transmaxillo-pterygoid endoscopic approach for lesions lateral to cavernous sinus. And if I have to talk, may add fourth now, that the Meckel's cave is being regularly approached by many of the endoscopic surgeons, especially the Columbus and the Pittsburgh group. where they are doing Meckel's cave exploration directly by the endonasal approach, going further laterally. The anatomy of the endonasal endoscopic approach was beautifully described by Dr. Joe way back in 2001. And he has actually written about the fact that you can reach inferior to the ICA, medial to the ICA very, very easily. So depending on how the involvement of the tumor is, you can decide if, and it can be done very, very safely. The cadaveric study by the Capabianca group also showed us that not only is it possible, but there are various surgical corridors from the endonasal endoscopic approach. And this was further brought into our notice by these 2 or 3 important papers. So NOSP first wrote about, as soon as the MRI became available in about 2 or 3 years time, NOSP wrote his paper about the invasion of the cavernous sinus by pituitary and how it influences our management. And this figure is, I think, known to most of us, where the transecting line tells us if this tumor is approachable or not approachable. And this not only decides the degree of removal of the tumor, it also probably decides several other factors about which approach should be used. And this was one of our initial cases when we were doing, this is acromegaly lady. We were doing uninostril approach then, but even there, it was possible to get into the cavernous sinus. You can see in a moment, we have removed the tumor in the sella. You can see the opposite sided cavernous sinus is being first cleared up completely. You can see the bulging ICA on that side. And then where the cavernous sinus is infiltrated, we have gone there. You can see the medial wall can be transgressed. And you can see multiple compartments of the cavernous sinus. And when the tumor is actually involving the cavernous sinus, there is not so much bleed. This case has been done way back in 2001. And in fact, at that time, not only we were handicapped by uninostril approach, but there was no flow seal or anything like that available. And we were dependent only on Surgicel at that time. I think the landmark paper for the cavernous sinus approach with endoscope came from this paper by Giorgio Frank, and Pasquini and Frank both taught us this approach in 2006 or 7. I can't remember very clearly, but they have been doing it since 1998, and they described about 141 cases in 2003 when they wrote up this chapter. They also wrote about this paper of first 402 patients later on in 2006, I think. And the conclusions were that you definitely can go inside the cavernous sinus in selected cases, soft tumors not invading the vessels or nerves, and it represents the most balanced technique regarding safety, tolerability, and efficacy. And one of the most important things was all these tumors were supposed to be treated by gamma knife. If you have a tumor in the cavernous sinus, go by gamma knife. So they have said that no, especially for functional tumors, surgery still plays a central role. And this is an important thing. And this is the case they operated. This was a residual tumor in the right cavernous sinus done by the endoscopic approach earlier. And this guy, we could not remove this. And he said that the workshop happened around the same time. So we re-explored this patient, and they have been, trying to remove this. And the flow seal was just introduced at that time. I think it is 2006 itself. And you can see the opening made into it. And the tumor was mainly anterior and inferior. So what is called today as NOS grade 3A. And that's where it is being done. And therefore, this was a workshop case. You can actually see in inset that Pasquini and Frank are talking to each other apart from talking to us, and the bleeding could be very easily taken care of by the flow seal, which we actually used for the first time. After this fact, when more than 400 cases were written about with pituitary, craniopharyngiomas, chordomas, etc. by Frank, NOSP had also started using endoscope, and he wrote about another paper to sort of modify his earlier classification of 1993. And he talked about invasion of cavernous sinus space in pituitary tumors with endoscopic verification. And this is a 2015 paper, and he says that it has completely changed his earlier classification. And then he talked about grade 0, grade 1, grade 2, depending on the boundary. And he has actually shown that you can probably clear up what he used to think was the tumor which is going into the C of the carotid. And then it was really the tumor which were lateral to the carotid and inferior to the carotid, which were most difficult, because superior, as Dr. Atul Goyal has talked about in his paper, the superior space in the cavernous sinus above the carotid is probably much more easily approachable than what we earlier believed. And therefore he concluded that it showed that the likelihood of surgically observed adenoma invasion rises and chances of GTR decreases. However, direct endoscopic visualization is the crucial difference that provides a decisive advantage over the microscopic technique. The direct endoscopic view confirmed the low rate of invasion in grade 1 tumor, grade 1 tumors, grade 2 tumors, and endoscopic verification of paracellular classification of grade 1 and grade 2 and grade 3 has become difficult. And then he suggested this grade 3A and 3B to differentiate between superior compartment of cavernous sinus involvement and the inferior compartment of cavernous sinus involvement, to show that which one is difficult. And I have put out a comment on this paper which Atul had written, which is very, very important, that the need and possibility of total resection depends on the tumor, how the tumor has presented, is it functional or non-functional, and probably endoscopy or microscopy, it is a question of what you are used to. But I think most people believe now, and I think the newer generation is making more and more familiar with endoscope and finding it probably that you can probably go into the cavernous sinus much more often than what you could do with microscope and remove this. The main reason I think this is superior is not because of superiority of any particular technique, but the very fact that you get a better lateral access to the tumor through an endoscope. If you go to the contralateral nostril, and I'm sure the angulation of microscope can probably achieve it if you use your speculum properly, but it can be difficult. So I'll just start with a NOS grade 3-4 tumor. You can see that this is a non-functioning tumor which has crossed the boundary of cavernous sinus above as well. If you look at this line, this much tumor is lying here. You can see the normal tumor is lying against the cavernous sinus wall on the opposite side. And this patient had presented with hypopituitarism. I'm trying to show this case just to show that, you can get a good exposure even on the microscope, but in endoscope, you can see much beyond your exposure. You can see both the lateral wall, and you can start doing an extracapsular kind of a dissection. Here I am getting to the cavernous sinus wall on one side, and then I would do the same on the opposite side. And you can see that the tumor was between the C of the carotid and could be virtually completely excised without trying too hard to remove it. Once you go extracapsular and create a plane, and the tumor is not too hard or fibrous, then it is possible to remove it. You just have to be very particular that you develop a good plane of dissection and make sure your diaphragm doesn't fall into various recesses to create problems for your visualization. You can probably go even beyond that by retracting, etc., but it becomes much easier if you do not allow that to happen. And this patient came to me 3 months later, and you can see not only a complete excision has been achieved, we have been able to maintain his normal pituitary, and this man not only improved in his vision, but he also improved in his hypopituitarism. He did not require any further hormonal replacement at all. This is the other lady where you can see that it is 270 degrees if you look at it over here and maybe over here, and you have a feeling that there is probably some inferior wall involvement even on this side, but this side it is very marked. This kind of a tumor has gone substantially into the cavernous sinus. So this is one of the most difficult, the 3B kind of a tumor. And here again the exposure becomes very important. And therefore in this case we don't usually take out turbinate, but here it was trimmed, and for better exposure we have now done a reverse flap just to make sure that we get enough. If we expose the carotid completely, we like to put a flap on that, some kind of a support. And you can see this is the carotid artery in the pit. One of the important things you can see actually that you can see the clavicle carotid quite well. And once you see the clavicle carotid quite well, you know that the cavernous sinus is bulging here. I am taking out the bone to expose the carotid artery further. And I know that the carotid is lying here, but I want to remove the bone over the carotid. The most important reason is unless I do that, I cannot retract it and I cannot go into the cavernous sinus properly. And then because the carotid is exposed here, I am making an incision into the sella proper. I am not trying to go into all the exposed area. And then you cut onto the carotid or into the cavernous sinus inside out with the scissors. Once you have done that, you start your usual resection. On this side, we have a clear. So you always start with the opposite cavernous sinus area to clean rather than going into the involved area, so that you have a good exposure here. And while removing this tumor, you will realize that the diaphragm has started coming down. Now we start removing the tumor on the side of the invasion. And you can see as the tumor is clearing up, the whole carotid artery is being skeletonized completely. The lateral inferior portion is being taken out. And this is possible because the tumor is suckable. If this tumor was hard or fibrous, I would have probably attempted, but I would not have insisted that it must come out, because of course there are other ways of cleaning it, as it was a non-functioning tumor. But here we could remove it completely, and you can see the whole carotid artery skeletonized, especially in a difficult kind of a 3B kind of extension. As I told you, we always put some fat and put a hadat flap over the exposed carotid, as there is no bony margin or bony cover on that. Schwartz has also written about it. I mean, any technique becomes popular only if more than one center says that it works for them. And Schwartz has written the same, that he finds that NOS 3-4 still remain problematic, but with endoscopic, he is getting a better mode of resection. Nishioka from Japan has also talked about the same thing in his experience of 41 patients, out of which 39 he could remove completely. Another example, this is a patient of Cushing's, where I actually excised this tumor 4 years earlier, before this patient came to me with a recurrence. And the recurrence occurred specifically in the cavernous sinus, and her ACTH levels went up again. And you can see that this is a fibrous kind of a tumor. You can see that the CSF is already dipping into the sella. So we decided that we are going to go directly into the cavernous sinus. We are not going to expose the sella this time. And we have completely skeletonized the carotid artery over here. Once you have done that, I'm still removing some more bone. You can see the carotid running here. You can see the intact dura over the sella, which has been earlier exposed. And I'm now opening over the tumor within the cavernous sinus. This compartment is completely within the cavernous sinus because there is no tumor in the sella. If I open the sella, I'll get CSF leak and nothing else. So I have now started removing this tumor. It is a pulpy tumor and therefore easier to remove. And as I'm removing this with curved kind of suctions, you can start seeing that the whole carotid is exposed again, and you can see the carotid skeletonized completely and the tumor coming out from now the superior wall, and you can see almost all walls of the. And this patient got a complete cure after surgery, and she has remained so for last 9.5 years now. Similar kind of experience has been written about by the Turkish team of Selin and others, who one of the earliest people who started doing this, and Gardner and Snyderman are probably responsible for now talking about the anatomical differentiation between the cavernous sinus component of the tumor, posterior, inferior, lateral, and therefore he says that the residual tumor rates came down substantially, though they were still about 79% in lateral. In all others, they came down below 20%. Another patient where it may not be possible. I mean, this patient, we know that the cavernous sinus is involved, and this is an acromegaly girl. And this is a girl in her reproductive period. So we did not want to treat her with radiation as far as possible. So we have exposed this. I have exposed the carotid completely on the left-hand side. I'm removing the tumor now. And we have been able to remove a substantial amount of tumor here. And you can see that the diaphragm has started falling down as soon as this tumor comes. And now I have entered the cavernous sinus. I can see the tumor, but the tumor is very fibrous, very hard. And there was no way I could remove this tumor. This arachnoid seen here. You can see the dural compartment here. And I'm trying to pull at this tumor with various instruments, try to dissect it out. And I'm using the carotid, I'm using the Doppler just to make sure that am I definitely on carotid, and yes. And therefore, I have decided that I am not going to remove this tumor. Once we have checked that, and then we treated this patient actually with gamma knife, and she has had a child after that. So I think the strategy has proved to be reasonably successful. This is another tumor which turned out to be very fibrous. I did a good excision by transphenol approach, but you can see the cavernous sinus component has remained here. Though I think retrospectively, I feel this was more than 12 years ago, that this is mostly superior to this, and I should have probably tried. But one of the main reasons was the consistency of the tumor that I could not get. And then I did the interdural cranial cavernous sinus approach and removed this almost completely. Another patient where something similar has been done. This patient could not tolerate cabergoline, and this was to be done for a prolactinoma. Again, a lady in reproductive age group. This is a lady who presented to us with third and sixth nerve paresis. You can see the left-sided cavernous sinus involvement in this chordoma. You can see that the bony erosion extends almost up to the lower clivus, and therefore it becomes very important to know what should be your lower limit when you are doing endoscopic surgery. You of course want to expose the left carotid because the tumor has gone into the left cavernous sinus. Once I have checked with navigation, then I go ahead, drill off all the bone, make sure that I see the normal dura at the bottom, normal dura on the top before I start debulking the tumor. Once I start debulking the tumor, I automatically, this is what is coming out against the dorsum sellae, and a little bit of cavernous sinus opening on the right side, which has been coagulated. And then from the right side cavernous sinus, now we are taking out the tumor, and you can again see that the whole carotid artery is skeletonized, and the tumor lateral to the carotid artery has also come out nicely when we are doing this. And we managed not only to get a complete excision, I was really surprised, pleasantly surprised. The next day, this woman had complete recovery of her third and sixth nerve paresis. I have not seen such a rapid recovery in any of my surgeries before. This is the lady, and you can see how far lateral you could get your exposure on this. Now, always it is not necessary to open the whole sphenoid and the sella. This is a patient who has specifically got a tumor which is near the area of the posterior clinoid. He presented exclusively with sixth nerve paresis, and you can see the erosion of the bone only over here. And we decided therefore just to get there, not to get into the sella at all. And we have taken out the bone only over here. Once we identified the carotid artery, we could remove this complete tumor, and the sella was not exposed or tackled at all. And the whole tumor could be taken out at the end along with the involved bone. And you can actually see it on the post-operative scan. Fat has been filled there. And this patient is about 18 years old, and this surgery is about 6 years ago, and he has remained tumor-free so far. What about a chordoma, which is involving the lateral part of the cavernous sinus? So this lady presented with drooping of eyelid, lateral rectus paresis as well, so third and sixth nerve paresis, and most of the tumor was lateral, as you can see. And therefore, we decided to do the interdural transcavernous approach. And I think Atul has shown you a beautiful picture, and you can actually see that the whole tumor could be removed very nicely. Her third nerve palsy, sixth nerve palsy, both improved considerably. In fact, when the tumor is occupying the cavernous sinus, there is no bleed, and I actually put an endoscope inside just to make sure that I have, removed tumor from all the walls. So that was quite nice to see that it could be done. Sorry, that video is missing from here. So anyway, we thought we got a good enough excision, and this lady was then subjected to radiation. My bad luck is that this lady came back to me 4 years later with a larger tumor. It looked softer and it looked quite well demarcated. But this time I was not sure how we should tackle this. Should we go back again in the same way? And then we thought that we will try out the what is called the lateral approach, the sphenoethmoid approach. And that is what we tried in this particular patient. You will be able to see that how the bony erosion is. And I will just show you with this that you have to take out the pterygoid plate and you have to go laterally to it. And once you have gone laterally, once you have identified the carotid artery, then you have to remove bone lateral to the carotid artery to get into this area, which is being done. You can see the whole area being skeletonized. And once you have done that, you can start seeing the tumor, which is lateral to the carotid. This is the carotid, this is the tumor. This is the sella is here. And once you have exposed this by your, you have to go through the back wall of the maxilla. So some part of it is removed. We are checking with, we are making sure that the carotid is not displaced. It is not coming in our way. And then we are opening into the tumor. And then it becomes easy to remove this. As it is not very vascular, you can put endoscope all into the cavity and make sure that you have removed everything. And you can see the carotid is bulging now here in the lateral wall, and the whole tumor could be removed as we saw from the MRI. But this was a more invasive kind of a tumor, and this again promptly recurred after which she had conventional radiation, and she still has some residual tumor, but reasonably stable tumor now about 8 years later. What about a meningioma? This is one patient. I had done a transcranial meningioma surgery where we removed the tumor from the optic foramen and the anterior clinoid, but this recurrence came up, and this recurrence came up with other involvement of the other optic nerve, and there we decided at this time that we'll go sphenoidally and transclavally. This the dorsum sellae has been removed. Most of the tumor is at the back, as you have seen, and the sella is intact. In fact, the pituitary is overlying this, and we have been able to remove this tumor by what is called the retropituitary or retrocellar approach, and we got a reasonably good excision. However, I think the Ki-67 index was something like 8%, and then this lady was subjected to radiation, SRS. So I would just end up by saying that endoscopic endonasal approach is useful. It is possible after expertise in endoscopic pituitary surgery. It needs expertise with extended techniques. MRCT images and vascular displacement is to be carefully studied. I think navigation and vascular Doppler is very, very important, at least for surgeons like us. I think there are people who can probably do a better job without these, but I think it is important these days to have this, and a judicious use of this technique can achieve a radical excision. Consistency of the tumor becomes important while doing this, and 360-degree ICA involvement probably is an absolute contraindication unless the tumor is very soft. Thank you very much for a patient listening.
That was a wonderful lecture, my dear Shekhar. And like what Paritosh showed, he's developing more and more experience in the field. You are still young in your attitudes, young in your lecturing, young in your teaching abilities. And you have been, persistent in teaching and giving the message of neurosurgery to all over the world in all corners of the field. And I give great credit to you and your enthusiasm. The enthusiasm will wane over the period of time. But what I am seeing, your enthusiasm has been increasing during the period. and what work you are doing, what cases you are showing, how you are going into cavernous sinus, how you are enthusiastically going directly into cavernous sinus. Many of the people will like to say, okay, forget about it, just give radiation and get done with it. You see, many of these, like Cushing, you showed only in the cavernous sinus, you showed one more tumor only in the cavernous sinus. That would have formed a very good indication for radiation. So what you have shown to the young people and everyone, not young, I don't call anybody young in neurosurgery. What you have shown is the enthusiasm and the will, the technique, and the collaboration. I am sure you must be collaborating with a good ENT doctor who is
Yes, I'm
helping
fortunate
you
to
in
have a
work.
good ENT colleague. And I think for functioning pituitary tumors, I think surgery still remains the gold standard because you can't get a cure by any other method, and you certainly can't get it instantly, which is the biggest advantage of surgery.
See, this attitude of collaboration is a unique attitude which some people have in abundance. Like how, people develop craniofacial surgery. And I give big compliment to Dr. Karapurkar. At that time, craniofacial surgery, he needed a plastic surgeon, which Dr. Goleria joined him. And both of them made a very formidable team and made a very huge team on craniofacial. Similarly, then he joined Dr. Ravi Ramakant and made a very huge contribution in endovascular. So these collaborative efforts, which Dr. Karapurkar had at that time, was unique, was not very commonly done at that period of time. And now we have been shown by others, and what you are showing is how collaborative efforts have taken your field of endovascular surgery to that endoscopic surgery. I'm not sure if Paritosh, you are working with some radiologist or you are working alone. What is your?
I have a radiologist, sir. I always keep a radiologist with me.
I
think
think
two
this
minds-
teamwork you will, this teamwork that must have helped you to a great extent in developing your art and developing the cases that you have generated during the time. I think I encourage teamwork. I couldn't make a team myself because that attitude is not in me. I don't, not that I don't believe in it, but I cannot, it is difficult for me, for anyone to partner me in surgical strategy because my techniques are a little bit here and there. But whatever has been shown, now I want to know from Aip. Aip, do you have a ENT doctor helping you in endoscopic work or you're doing it alone? Aip, you are muted.
You have to unmute yourself, I.
Well, I have an ENT colleague, and I completely believe in the ENT guys doing the exposure part and the closure part because it's something as big as the tumor itself. That's what I believe. So all our approaches, all these complex approaches, I have an excellent ENT colleague helping me out. And we, in fact, recently started an ENT fellowship for ENT surgeons for skull base, so that two guys constantly are there with us, who post MS ENT guys are with us, so they keep on, helping us out, and they keep on advancing so that we can also advance.
All in all, I have to say that, I really enjoyed Paritosh's, I was a little bit not happy when he left NIMHANS to the extent I held his ears and pulled it to the extent that he almost cried that why the hell you left NIMHANS. But then he has shown that wherever he has gone, I don't know where he has gone, but he has done, and the whole world is open for him. And I wish him all the good luck and all the best, and do good work, my dear Paritosh. Similarly, I will say, Aip has been a traveler. I have gone from this place to that place in looking for good avenues, good work, and ambitious, from his attitude, from the way he talks, you can see how, positive the way, this is the attitude of a neurosurgeon that we have. And we learn from our seniors and from our teachers, and we just go ahead in our path of learning good neurosurgery. And what Shekhar is showing, the enthusiasm at his stage of neurosurgery. And all in all, I have a feeling, and I hope Shekhar agrees, that we had a wonderful session. Shekhar, what do you have to say?
Yes, yes.
And
It
I
was
have to
nice.
thank
I
John
think we
for
have seen
organizing
various
it.
aspects.
And John for organizing the whole show. And for,
Sure.
no matter what, John has taken the message of neurosurgery all nook and corners of the world, and for everybody to see and learn and, experience of young and old and everybody. So thank you, John, for organizing this for us. And whoever has watched, I am not sure. John, what do you have to say?
This was fun today. And
You
plus
see,
some learning.
yeah, no question about it. Lots of learning. And most important thing which I didn't say is that I am also, building muscles in the gym nowadays, trying to build, as I was showing, I have 6 packs and 8 packs. John, you listen to this. And I am also, you see, developing these muscles. And my enthusiasm is growing by days and by as the time goes.
So, Atul, I have to say, this is the best time in history to practice medicine, I think.
No, the learning, the best time to learn neurosurgery, best time to learn medicine. You see how many lectures you can sit down in your room, comfort of your room, and listen to everybody else in the world. You can just see the history. If somebody has given lecture 1 year ago or 6 months ago, you can put it on the computer and see it. If somebody has given lecture in Yemen, in Ecuador, in Latin America, anywhere, you can sit down in front of your computer and see. I think such learning process. And also, John, I have to tell you, although I'm traveling quite a bit, but my feeling is traveling gives you exposure to an extent. It takes away so much of your time. This is the best way to give lectures and to talk to people. John.
Yes, it's the best. And we look forward to you guys speaking in 2
agree.
weeks.
I
Correct?
think lot of meetings should probably shorten up. I think personal appearance is probably required mainly for hands-on training and workshops now. I think we can shift a lot of this learning stuff on virtual platform, because I think all of us are using it for everything in life now.
Yeah.
It's not only neurosurgery.
Okay, Shekhar, you give your last words and then I will ask.
No, I'm very happy to learn. I think appropriate use of flow diverters, appropriate use of bypass surgery, another excellent course on dural anatomy and how it helps us to serve a patient properly. And I hope I have contributed to some extent by telling you that what is the scope of endoscopy today in getting to more complex lesions into cavernous sinus as well. Thank you very much for the day. John, and
Aip,
everyone
you
else.
want to say a few words, Aip, quickly?
Yeah. Over the next few parts of this grand rounds, I'd like to show that how we have shifted from a microscope concept to an exoscope concept. And although the shift has been a bit difficult, at my age, I may not saying I'm old, but definitely at 47, I'm not getting younger. So it has been difficult. So I spent a month in the lab, and then after that started off with small cases. Now we're doing almost everything. I haven't used the Kinevo in the past 3 months. I've never used it at all. So it is so comfortable.
Let's have a session on surgical visualization.
Yes.
Various
Absolutely.
aspects of it. Yeah, I think we can do it. You can talk about scopes. If at all there are any limitations of your microscopic surgery, I can probably give you an overview of. I've used exoscope a little bit, but I can probably give you an overall picture of what I think is the future, and you can probably show what the future holds as in your experience. If anybody else can contribute, I think Yadav does a lot of work on exoscope. We can probably ask him if he can contribute.
Okay, Paritosh,
Yes.
just say a few words and we wrap up the story.
I think it was a fascinating session. Listening to you is always a pleasure, as is with Dr. Dev Pujari. And I loved this session, and I look forward to more of you listening, especially for the newer advances like exoscopes and stuff like that, which I haven't used. Thank you, John, again for organizing this. Thanks very much.
Thank you. John, you want to say something?
Yeah, okay. I'd like to thank everyone for putting their valuable time to teach the people of the world in this topic. And we'll see you in 2 weeks, correct?
Okay, okay, Johns.
Thank you,
Bye-bye.
everybody.
Thank
Thank
you.
you.
Bye-bye. Bye-bye.
Thank you. Bye.